My name is Dr. Nabil Saba. I'm a head and neck cancer medical oncologist at Emory University, the Winship Cancer Institute, and I'm going to be discussing today the NEOPOLIS trial, which is NRG-HN015.
So, can you tell us about what the key question is that NRG-HN015 seeks to answer?
The standard of care for patients with head and neck squamous cell carcinoma who have their cancer come back locally and who still can have surgical resection after having had prior treatment, usually with radiation or possibly surgery, is still salvage surgical resection in 2026. However, with the advent of systemic therapy and the role of systemic therapy in the definitive treatment setting, namely here immunotherapy or chemotherapy, this trial is intending to look at the outcome of event-free survival for patients who receive chemotherapy prior to salvage surgery or chemo-immunotherapy prior to salvage surgery, and basically compare it to the current standard, which is basically going straight to salvage surgery. So the trial will have three arms: chemotherapy arm, followed by salvage surgery, a chemo-immunotherapy arm, followed by salvage surgery, and the standard arm, which is salvage surgery. All of these will be followed by postoperative adjuvant therapy, depending on the pathologic risks for each of the patients.
Do you think you can briefly describe the trial a little bit more in detail, and what sites or hospitals are expected to be involved? Do you have an idea on that?
Yeah, so I think the reason we really felt that this study needed to happen is the lack of progress that has happened in the area of salvage therapy for head and neck squamous cell carcinoma. And so we felt that it is time to try to basically design, which is actually, I think, the very first NCTN prospective clinical trial addressing the salvage surgery question in patients with head and neck cancer. It is expected to be open, I would think, at all the NRG participating sites for our team, head and neck cancer. So it will be multiple institutions within. We're looking still to see if it will be opening outside the US. I think we don't have a final approval to that, but we would certainly love if we could also open it outside the US. I know that some centers in Ireland, for example, have expressed interest in opening the trial, as well as possibly Canadian sites as well.
And sort of segueing very nicely into the next question. So, what practical guidance or advice would you give the different NRG sites on coordinating the neoadjuvant therapy window and in order to prevent delays in surgery?
This is a very good question. I think the trial is actually very specific about this question, and essentially the requirement is that salvage surgery should be performed 6 to 10 weeks post cycle 1, day 1, for the patients who are randomized to the experimental arms. And so I think it's very imperative for the sites to evaluate patients within a multidisciplinary fashion, have the patient seen initially, certainly by the surgical team, but also by your medical oncologist and radiation oncologist, which is happening, I think, in a large proportion of centers that treat head and neck cancer. And so there needs to be some form of coordination here in terms of making sure the protocol requirements are followed. But that applies to any study, whether it's head and neck or not, essentially to make sure that these windows essentially are obeyed. Because if we don't obey that, then these are deviations, obviously.
Very nice. For you, which would be the ideal patient for enrollment, and what common barriers or eligibility nuances, maybe as PD-L1 enrichment, should NRG investigators watch to boost the accrual?
Yeah, thank you for that excellent question. I think one important aspect is that sites or surgical colleagues or any colleagues may be tempted to enroll patients who they think need cytoreduction to basically potentially have easier surgery. I would very quickly tell these investigators, please don't do that. This is not a trial that is currently intending to de-intensify therapy. And actually, patients with tumors that are borderline resectable should be avoided as far as offering this study, because we don't want these patients to have progression on systemic therapy and potentially result in unresectable disease. And so these marginally resectable tumors should be avoided. I think we want patients who clearly have surgical evaluations initially confirming resectability, because they could be ending up on any of these arms for this study. You mentioned PDL1. Yes, we want patients to have PDL1 positive disease. And the definition here is by CPS score, they should have a CPS score of 1 or higher. In addition, they should have failed radiation therapy. So these patients should have received prior radiation therapy. And the protocol essentially mandates that at least 50% of the tumor volume must have been previously radiated to at least 40 gray or higher to be able to go on. Both HPV positive and HPV negative histologies are accepted, and the different subtypes of squamous cell cancers of the head and neck, mucosal squamous cell cancers are allowed on the study.
Makes perfect sense. Thank you very much. And to close out the interview, we'd like to ask one final question. So, looking ahead and looking into the future, what do you hope that NRG-HN015 will achieve for patients with recurrent head and neck cancer? And what would your final message be to your colleagues at NRG, at Emory, and beyond on why we should prioritize this trial?
Yes. I would say that this trial iteration has been going on prior to activation for quite some time, and it sort of survived the test of time. I would say that it is time now, with the approval of immunotherapy in the definitive preoperative setting, to actually start slowly moving systemic therapy into the salvage therapy setting. This is a completely different setting than the primary preoperative setting, which is why we need to investigate chemotherapy. We need to investigate chemo-immunotherapy as a first step. The trial stands to teach us a lot. I think we will have tissue samples from patients on 3 arms, so we will be able to assess biomarkers that may correlate with clinical outcomes, namely event-free survival, but other outcomes as well. I think the trial will clearly open and pave the way for future agents, and there are multiple agents that are being developed in the recurrent metastatic setting, however, that are not currently used in the salvage therapy setting. And so the trial, I believe, will open the door to future investigation of multiple of these agents, specifically agents that may be approved soon in the recurrent metastatic setting. And so I think this is a first step in the salvage therapy setting, and I encourage people because of this to consider the NEOPOLIS trial as a priority and to try to accrue patients on this very important study.
Thank you very much, Dr. Saba.